Okay, good morning, everybody. Dan Bates, President and CEO, Greater Hamilton Chamber of Commerce. We're really glad to have all of you joining us today on Coffee and Conversation. These have become really sought after, meaningful presentations. Those of you who are joining us on Zoom, you can just ask your questions, raise your hand, or just speak up and ask the presenter. Those of you who are joining us on Facebook Live, if you type in your question, then Tiffany will repeat that to the presenter and answer your question for you. So with that, I think we're going to do self-introductions. Once again, thanks for joining us. I'm turning it over to Laura.
All right. Hey, everybody. I'm Laura Merrill with the Greater Hamilton Chamber. Glad you could all join us today. I will just go across my screen and we'll introduce ourselves, your name, what company you're with. Judy, you're my first one.
Hello, I'm Judy Duarte. I'm the intern with the Greater Hamilton Chamber of Commerce.
Lisa?
Hi, I'm Lisa Sandlin. The company's name is EmpowerWorks, and we teach you how to own your life, health, and wealth through education, design, and finance.
Nancy?
Nancy O'Neill with the Greater Hamilton Chamber.
Liz, we'll come back to you. Liz is our presenter for today. We're excited to have her here. Ann?
Hi, I'm Ann Arnett, and I'm with Gateway Springs Health Campus. We are a new senior living community that's coming to Hamilton. We'll be open early 2021. We'll have assisted living, memory care, and skilled nursing.
And Aaron?
Hello, my name is Aaron Gardner. I'm also an intern for the Greater Hamilton.
Awesome. All right. Tiff, are you ready?
I'm Tiffany Grubb with the Greater Hamilton Chamber.
All right. So we're excited to have everybody here today. We're excited to have Liz Mohr with Mercy Health Partners tell us a little bit about what is going on over at Mercy. Liz, we'll let you take it away.
Okay. My name is Liz Mohr. I'm the Chief Financial Officer for Mercy Health Fairfield Hospital. Happy that Laura invited me to present to you all today. Hopefully I do well and you guys invite me back some other time. But I'm just going to give a little brief overview of Bon Secours Mercy Health, of which Fairfield Hospital is a part of, as well as dig a little bit more into just healthcare finances in general, and focus a lot on the patient, the provider, the payer, and the payment. I know that healthcare finances can be a little bit difficult to understand at times, so hopefully you leave here understanding it a little bit more. I still learn every day as well, and I've been in healthcare for 15 years in the accounting and finance realm, and I've actually been with Bon Secours Mercy Health. We've gone through lots of mergers and name changes over the years, but I've been with the organization for 12 and a half years in various roles. So hopefully you learned something from me today. I'm going to go ahead and share my screen here. I have a presentation to give, and feel free to ask questions as you go as well. Let me do my slideshow here. Okay, can you see my screen?
Yes.
Okay, and hopefully you don't see my notes, do you? You see just the slides? Okay, so again, I'm with Mercy Health Fairfield Hospital. Just give you a brief overview of our leadership team here. Justin Kruger is our president. Dr. Stephen Fagans is our interim Vice President of Medical Affairs. Ramona Cheek is our Chief Nursing Officer. And myself, Liz Mohr, the Chief Financial Officer. We currently have a vacancy with our Chief Operating Officer and sourcing candidates for that role. Again, our mission is to extend the compassionate ministry of Jesus by improving the health and well-being of our communities and bring good help to those in need, especially people who are poor, dying, and underserved. And then, of course, our values are just the human dignity, integrity, compassion, stewardship, and service. A few questions that I want you to ask yourself as we go through this presentation, and maybe shoot out some of your answers at the end, is just with our community vision. We want to know, what vision do you have for healthcare in your community? What's important to you in terms of where you seek healthcare, and then why is it important to you? We believe we know, but it's always interesting to hear from the patient, because obviously we don't know everything. So we really want to hear the answers to those from each and every one of you. Our ministry's vision is obviously to strive to be that health system that patients and communities deserve. So we want to be a place where employees want to work, physicians want to practice, and patients want to come and receive that care from those providers. This is just Bon Secours Mercy Health overall. We are one of the 5 largest Catholic healthcare systems in the US. And we are actually the largest private provider in Ireland. We have more than 1,000 sites of care in the US and in Ireland. We have more than $10 billion in pro forma net operating revenue. And then we actually provide, this is very interesting, more than $2 million a day in community benefit. That is free healthcare services in our ministry. We have 50 hospitals as part of our system. And those 50 hospitals and other sites of care comprise of 2,600 providers here in the United States, 450 consultants in Ireland, and over 60,000 associates as part of our ministry. This is the Cincinnati market, just a small chunk of those 50 hospitals. We have 5 of those 50 here in the Cincinnati market. You can see here is Fairfield Hospital, where I reside. We have some smatterings of facilities, physician practices up in the Hamilton and Oxford locations. And then we also added last year another physician practice at Kyle's Station. We provide cardiology and physical therapy up in Oxford as well. And then just 2019, to give you an idea of the total number of patients that we really see, we had over 15,000 admissions and observations. Those are inpatients. We did close to 8,000 surgeries in 2019 here at our facility. We see over 50,000 patients a year in our emergency room. That's almost about 140 patients, 130, 140 patients a day. And then almost 1,500 births here at Fairfield. And then just the economic impact here in our North Market alone, at Fairfield Hospital, we contributed $91 million in salary, wages, and benefits in 2019 with our associates that are on staff. And here at Fairfield, you know, I mentioned the $2 million a day in community benefit throughout our ministry. Fairfield in 2019 provided $18 million of that on an annual basis. And the majority of that is just subsidized health services, but it also includes in-kind contributions, community health improvement services. Anytime you see us out volunteering, those hours go towards our community benefit. And then I want to jump into some of the challenges that are impacting our finances within healthcare. One of the biggest things is just volume leakage. You can see new healthcare providers going up everywhere on every street corner, and it's really to provide close access to patients. So as we see payers continue to reduce reimbursement rates, and healthcare providers need to treat larger volume of patients to break even. So just to show you that increased competition, I pulled just the short-term acute facilities. So really the hospitals that you see on every street corner, it feels like, if you go up 75 there at 129. Butler County, we have 7 acute care hospitals within Butler County alone. Hamilton County has 11, and then Warren County just has 1. Some of the interesting facts here is that there's 88 counties in the state of Ohio with 188 hospitals. The average number of hospitals in a county is 2.1. Butler County has 7. Hamilton County has 11, and we're right next to each other. So we're very saturated with hospitals. We have 11 of those 88 counties that don't have any hospitals. So we are very fortunate and lucky to have all of these hospitals available to us and at our disposal. And then you can see here that there's 44 counties that only have 1 hospital and 18 counties that have 2 hospitals. So again, we just have a large quantity that makes it even more competitive, and we really have to be at the top of our game here because it is a very competitive market here in Cincinnati. The other thing that we are seeing, I mentioned the declining reimbursement rates. So we have to figure out how to bend that cost curve. And we also see the payer mix shifting from more of commercial to government. And we'll get a little bit more into that later into the presentation regarding that payment structure with commercial and government payers. But as we see more of the baby boom moving from employer-based health plans to Medicare and Medicare Advantage plans, that's really taking a hit to our bottom lines at all of our facilities. The changing reimbursement models. We're used to, for decades, seeing the fee-for-service, really, which is a per-click model. So you come in and you have a chest x-ray, or you come in and have lab tests done. There's a payment for each of those. So like I said, how many chest x-rays, how many MRIs can we perform? That's going away. And we're really moving to value-based reimbursement and bundled payments. So value-based, how many readmissions do we have here at our hospital? We don't want to have readmissions. We want our patients to be well, get well, and be able to stay well at home. We don't want them to have to come back here into our facility. So we are being penalized for readmissions. So we need to focus on that. Hospital-acquired conditions. Those are, if a patient contracts C. diff or something while in our facility, we're penalized for that. So we need to make sure that you don't end up with something else other than what you came in with to be treated, or we will be penalized for that, as well as meaningful use. So our electronic healthcare record system, we use Epic here. So all of the insurance companies are really wanting us to go electric and not paper. And we are all electronic now. Bundled payments, that's more for, we have CJR there, which is our joint replacement program. And that's where insurance companies will pay one payment. Say you get $10,000 for a total joint replacement. Well, that is supposed to cover the surgeon, any physicians that see you, your stay in the hospital if you have to stay, and even your therapy services and any services beyond once you discharge here related to that joint replacement. So that's what we call a bundled payment. And then revenue cycle management. It's getting more and more complex to insurance companies make it very complex for us to really get a clean claim out the door and not see any denials come back. So we're really focused on the revenue cycle, on the cost to collect. So how many times does an invoice or a bill, a claim, have to be touched? We want it to be touched the least amount of times before it gets out the door to insurance. So we're really focused on reducing those number of touch points. And we can see here a couple areas. Our revenue integrity, we need to make sure the documentation's accurate, that we code those claims correctly, and then when we receive payment, that it's paid correctly, because there are many times that it's not paid correctly. And insurance companies are hoping you don't catch that. So we really focus on that to make sure we're getting paid for the work that we do. And then denials. It's really, this is just kind of relationship 101. We have to build those relationships just like anyone does in any organization, even with your peers and coworkers. We have to build those relationships with the payers, so all of the insurance companies. And a stronger relationship means the better outcome we're going to have with getting claims paid timely and cleanly as well. And then just making sure that we have the most accurate information at the time that you present. So we need to make sure that we have your correct demographics, that the reason that you're here, the medical necessity, that it meets medical necessity, that you really need to have that test done or that surgery done. And then we need to make sure that if it needs to be authorized prior to the date of service, that we have that from the insurance company, that they say, yes, it's okay for Sally Joe to have this procedure. And then just some of the finance functions that I work more as a liaison for here between the hospital and support services at the home office is our accounting department, financial planning, reimbursement, revenue cycle, the business planning and development, internal audit, compliance. The reason I have revenue cycle highlighted here is because that's what I want to focus on here in the presentation that I'm giving, because that's really what the patients, their stresses after they leave the hospital is really once they receive that bill. So I'd like to just provide some education here around our revenue cycle functions. So today we're gonna establish a foundation of revenue cycle based on the 4 Ps. So number 1 is the patient. We need to make sure that patient is at the center of everything that we do. Provider, number 2, payer, and then the payment. So the patient is you or I, the person who receives the medical services from the medical provider and may receive insurance coverage or benefits from the payer. Some common types of patients that we see are inpatient, outpatient, observation. Those are patients that are usually here less than 48 hours. So we're trying to determine what's really happening. They may not qualify for inpatient status yet. We're running a bunch of tests. And maybe those tests come back to find something critical, and that observation patient could potentially convert to inpatient. But if it's not as critical of a diagnosis, those tests come back good, they're probably going to stay observation status and just be discharged and follow up with a specialist or with their primary care physician, and we'll make sure that those appointments are made. Emergency, some of the patients that come in through the emergency are just treated and discharged. Some patients that come into the emergency room will be treated, stabilized in the ER, and maybe admitted upstairs if their diagnosis is critical enough. And then we see clinic patients, We have an OB clinic here that we provide services for. And then series account patients are more like cardiac rehab. So maybe after heart surgery, a patient needs to go to cardiac rehab, and they're coming a couple days a week. Instead of registering them every time they come, we set up a series account. So it's a one-time account for the whole month. So that's what we call series patients. And then just some of basic patient terminology. We have a subscriber or policy holder, which many of us may be one of those, which is the primary holder of an insurance policy. And then we have members or beneficiaries, an individual who has coverage from a health insurance plan. And then the guarantor or responsible party is the person who signs off as financially responsible for that payment when you come here to seek healthcare services. So for many minors, children under the age of 18, that guarantor is going to be the patient or a legal guardian who brings that patient in for treatment. A typical workflow for a patient as they come into our facility really sometimes starts over the phone. If you're not coming in through the emergency room, you're starting over the phone with our scheduling department. And that scheduling department is obtaining your insurance information, and they're checking medical necessity for whatever procedure that is that you're going to have. Then we go through pre-registration. They're going to complete that registration, everything that scheduling didn't obtain. There may be some demographics that are missing, but that's what's going to happen at the pre-registration phase. And then they're also going to estimate your patient liability, what you may owe based on what you're coming in here for. And they're going to collect that up front from you. And then we have insurance verification. Maybe you're having a surgery or a CAT scan or an MRI. So what we need to do is we need to validate that your insurance covers that. And we also submit that authorization to insurance to make sure that they're going to cover that for you. Even though your insurance covers those types of procedures, it doesn't mean that they're going to cover it for this date of service that you're coming in. So we need to obtain that authorization from insurance that they verify the reason that you're coming in for, and that they're okay with that and they're going to pay for that. It's very important that we collect that authorization, because if we don't and it is not authorized, we risk a denial. And that denial could come back and either we have to write it off completely, or the patient becomes responsible for the entire invoice. And then the registration, when you come here on site, all of these scheduling, pre-registration, and insurance verification happens before you even step foot in the building. The registration piece happens once you come into our facility. So we'll complete any missing items that maybe you didn't have at that time. And then we'll collect the point of service estimated liability if it wasn't collected over the phone. And then we'll make sure we check the patient in before they proceed to the department in which they're having their test or procedure. If for chance a patient, can't afford the services that they are seeking, then we'll consult public benefits, and they'll assist the patient with aid, charity, getting them covered and enrolled in an insurance plan. We have folks here on site that work with patients every day to enroll them in Medicaid and Medicare, or just any type of coverage, help our patients fill out charity applications. So we do have someone here at our patient's disposal. And then they also monitor any financial assistance status. So those are just applications that our patients are completing, and those public benefits specialists will continue to monitor to make sure that those are still flowing through the system seamlessly. And if there's anything that gets kicked back saying that, you know, maybe they need additional information, they'll follow up with the patient to try to obtain that so that that patient can get approved for whichever assistance that they applied for. Moving on to the provider are any healthcare professionals, groups of healthcare professionals, hospitals, other facilities that provide healthcare services to our patients. So doctors, the hospital, the clinic, the physician extenders, the home health agency. When we think doctors, there's multiple kinds of doctors. We have hospitalists, which are the doctors that round on you when you're in a hospital. In the old days, it used to probably be your primary care physician that would come to the hospital and round on you if you were inpatient. Well, today, we contract with what we call hospitalists. So they're here so that your primary care physician doesn't have to come in and see you within the hospital, and they can continue to see the rest of their patient panel on an outpatient basis in their practice. But there will be communication back and forth between the hospitalist and your primary care. And most notably, sometimes it's through the electronic medical record. We have anesthesiologists for our surgical patients, radiologists, surgeons, pathologists. So it's very important to understand everyone that's laying eyes on you and seeing you, because this is where it starts to get complicated. You may receive a bill from every single one of those. So anyone that touches that patient, they are billing for their services, okay? And that's where things start to get complicated. You'll start to see all of the bills come in, and it's not just going to be for your hospital stay. So basic provider terminology, the doctor obviously is a graduate of an accredited medical school who's licensed to practice medicine. The physician extender are things that people that we see every day in a physician practice, nurse practitioners, physician assistants, clinical nurse specialists. So they're non-physicians who deliver medical care, and they're always under the supervision of a physician. They have to have a physician be able to sign off on things for them. And then we have home health agencies who manage the care of our patients in their homes. So once you discharge from a facility and maybe you have needs at home, we will transition you over to a home health agency that will check in on you at home. And then the payer, who's commonly referred to as an insurance company, Humana, United, Medicare, Medicaid. So we get into the various different kinds of insurance agencies. So commercial agencies are your Blue Cross Blue Shields, your Humana, your United, your Cigna. And then you have managed care agencies, our HMOs. You've probably heard some of these in your lifetime, HMOs, PPOs, POS, EPOs. So we have a health maintenance organization, there's preferred provider organizations, there's point of service, and there's employer provider organizations. And then we have our common government agencies, Medicare, Medicaid, TRICARE. So just to give a little bit of background on the managed care agencies, the HMOs, the health maintenance organizations, those typically require you to have a primary care physician, and they only cover in-network services, and they often don't include deductible costs. So you typically don't have a deductible with HMOs. Where a preferred provider organization or a PPO, they don't require a primary care physician. They cover in-network and out-of-network services. So they cover you to go to either. And they often do include deductibles and co-insurances. And you can also sometimes see a physician without a referral. So most insurance companies require you to have a referral from, say, a primary care physician to go see a general surgeon or an orthopedic surgeon. But with a PPO, sometimes you do not need to have that referral. Our point of service agency, the POS, they do not require a primary care physician. They cover in and out network services, and they include co-pays, co-insurance, and deductibles. So they're very similar to a PPO, but the difference is the point of service is lower cost with fewer choices. And that's kind of the main difference between a PPO and a POS. And then the employer provider organization is a plan that's offered by health systems or networks created for a specific employer or a group. And they recommend you have a primary care physician. They cover in-network only. And it also includes a deductible, copay, and co-insurance. So you would have all of those with an EPO. When we move on to government agencies, Medicare is the federal program governed by the Center of Medicare and Medicaid Services. And it includes 4 parts. You have Part A, which covers the hospital. Medicare Part B is medical. So if you're going to see your primary care physician or a specialist. Part C is replacement. And Part D, it covers your prescription drugs. Medicaid is actually state administered. It's a voluntary program, and it's based on financial welfare with variations by state for income and assets. TRICARE is a federal program for our active military, retired military, and military dependents, and former military spouses. And then for payment, which is our 4th P, or actually our 3rd P, so the estimated or expected amount to be reimbursed to the provider from the guarantor or the payer. So there's 2 different types of payments that we see here at the hospital. There's the patient liability, which would be your liability under your insurance that you have. And then there's the payer responsibility, so that your insurance company covers. The patient liability is actually the dollar amount due from that guarantor for the services provided to the patient. And it could be anything from the copay, if you owe a copay for that service, the deductible, co-insurance, and then obviously all of this goes towards your maximum out of pocket. So a lot of plans have a maximum out of pocket. And once you reach that out of pocket, your services would be covered at 100%. That out of pocket starts over each calendar year. So that's why we start to see busier ORs at the end of the year in our hospitals, is because we have a lot of folks that have met their out of pocket and decide to have that procedure, that test or something at the end of the year where they're not going to owe anything because they've met that out of pocket. Just to give you a little bit of an example of patient liability versus the payer responsibility. And I actually have a couple examples. One, say a patient comes in for a lab test, and our gross charges for that lab test are $100. So we put a charge in for $100. Well, insurance has contracts with us as a healthcare facility, and they say, you know, we do not owe $100. Our contractual rate is really, say, $55. So we end up doing an insurance adjustment, which is what we call a contractual. That's our contractual agreement with that insurance company. And we go ahead and we reduce that $100 by the $45. So now that balance is $55. Well, you as, that policy holder for your insurance, you have co-insurance that's owed. Insurance pays 80%, and you as the patient pay 20%. Say that's your co-insurance agreement with your insurance company. So we take that remaining $55 and we end up taking 20% of that, which is $11. That's how much you as the patient would owe when you come here for that lab service. And then the insurance company would pay the remaining $44, okay? And that $11 that you owe goes towards that maximum out of pocket. So say you have a $4,000 out of pocket for the year, we would reduce that $4,000 by the $11 that you just paid. And that goes for any service that you receive here at the facility. And then the payer responsibility, like I said, it's based on the charges submitted on the claim. And we have specific forms that we have to use to submit these claims to these insurance companies. They all have their preferred way that we submit these, and these are common forms that we use, a UB04 and an HCFA. And then the different payment types that we see are from a fee schedule, which lab is a more common service that we see paid from a fee schedule by insurance companies. We have per diem payments. So say a patient comes in for rehab services, inpatient rehab services. We may have some insurance companies that pay a certain amount per day that patient's here. So that's a per diem rate. And then we have the package bundled payment, which I kind of talked about a little earlier on another slide, which is going to be more like the total joints that we talked about, where that bundled payment is the payment for all services that patient received for that service. Physicians, the staff that were in the room, to the care up on the floor if they ended up getting admitted. Then we have a case rate, which is most commonly the most common payment structure that we receive for surgeries. And then we have a DRG and an MSDRG, which is a diagnosis-related group. And DRG is more for your non-Medicare patients, while the MSDRG is used for Medicare patients. And DRG is usually the method of payment for inpatients. So it's sort of like a bundled payment where we receive one payment based on your primary diagnosis. So if you're in here for heart failure, we're going to get one payment for all of your care here. So if you received a chest x-ray and had some lab work done, and any services within this hospital would be paid under that DRG. There would not be separate claims going out the door just for the chest x-ray, and one for lab work that was done, and another one for the inpatient stay for that room and board charge. We would not have separate claims. It would all be one, and we'd get one payment for that. And then just a little bit on the back end for revenue cycle. We have our billing department, which they're reviewing all of those claims and correcting them before they go out the door to the insurance company. And they're also making sure that they get submitted timely. Insurance companies in our contract give us deadlines to have invoices to them. So many of them are within 30, 60, 90 days. Most of them are 30 days within the date of, at the end of the date of service. So if someone was an inpatient and they were discharged, from that time of discharge, you have X number of days based on our contract with that insurance company to get that claim submitted to them, which may seem like a lot of time, but when we're talking millions of patients within our ministry, it's really not a ton of time. And then we have our accounts receivable department. So they're following up with payers on any outstanding payments, and they're also appealing any technical denials. Technical denials are things like maybe missing one of the demographics when we went to register you, or one number was fat fingered, you know, on your policy number. Then we have our cash posting or cash application team. They are applying the payments to the accounts, and they're reviewing any credit balances on those accounts that may turn into a refund to the patient or to the insurance. So they're looking at that to see who's owed that credit. Then we have our payment integrity team. They are the ones overturning the clinical denials. So I mentioned technical denials before. We also receive clinical denials for medical necessity and things of that nature. They also review over and underpayments and apply contract language to our electronic healthcare record for appropriate billing. So all of our claims go through our electronic healthcare record, and we actually have codes in the back that match our contracts with those payers, where they're actually scrubbing that claim to make sure everything's accurate before it goes out the door, because we want to make sure that it goes out clean. And then we have our customer service department. So there are a typical call center that you see with any organization. They answer statement questions, they're collecting payment, and they're also helping our patients set up payment plans. Because as we all know, some of those invoices can be hefty, and we recognize that they can't be paid in 1 month. So we will work with our patients to set up payment plans that work within their home budget. And then some of the challenges, we talked about healthcare challenges, but these are, or healthcare finance challenges, but these are challenges facing healthcare in general. Number one, the pandemic that we're in right now. COVID-19 has thrown us all for a loop. So we, every day, are trying just to figure out how to live in our new world. I know that that's everywhere. That's out in the community with any business. And then just our area health metrics. We all have specific key performance indicators that we need to meet. And again, the competition, you know, with trying to meet those metrics, it becomes a challenge. And then the Affordable Care Act, which came into law in 2010, has really threatened Medicaid expansion, which isn't a good thing in the healthcare world. Everyone may think that that's good because everyone's you know, getting insurance, but when you're getting Medicaid, Medicaid is one of the providers that we receive the least amount of reimbursement from for patients. We don't even come close to breaking even with Medicaid reimbursement. Medicare, it's tough to get to break even with them. It's a little bit easier than Medicaid. But again, as our commercial payers keep reducing reimbursement rates in our contracts, that's where we're really struggling, because we know that we can't survive with just Medicare and Medicaid reimbursement. So that's going to continue to challenge us here in healthcare and make us, you know, think a little bit, be a little bit wiser. And then again, I mentioned payer mix shift changes. I said more folks are moving from commercial to the Medicare, Medicaid plans. We talked about the baby boomers earlier. That impacts us greatly here within the healthcare sector. Then we have the government regulations. We talked about some of those challenges with readmissions, healthcare acquired conditions, and just the regulations in general to function day to day. We are held to the Ohio Department of Health standards and Joint Commission. CMS uses Joint Commission to regulate us. And we are surveyed triannually with Joint Commission. And they do a 4-day on-site survey, and they look under, you know, the hood, per se. They're looking at everything. They're looking at medical records. They bring in a physician, a nurse surveyor, and they bring in an environment of care surveyor that are looking at our records to make sure that we are keeping track of everything, and that we are doing all of our preventative maintenance in our facility and keeping everything up to snuff. And then I talked about reimbursement reductions already. A huge challenge there. A lot of these go hand in hand with each other. High deductible plans, those are a challenge for us as well, and collecting that. It's much easier to collect from an insurance company than it is from you or I. We all have very fixed income. And you come in unexpectedly with a health problem and don't expect that, and it's a hit to your budget. So those high deductible plans are a challenge for us. And then obviously our increased competition. We talked about how many hospitals we have here just within Butler County and Hamilton County alone, and what that average is throughout the state. And that competition is real here for us. And then capital. Capital and really goes hand in hand with the increased competition as well. Our capital, just to keep our facility alive and going, and the equipment to treat and take care of our patients, it's expensive. And we have to be very smart and strategic in what we invest our money in when it comes to capital. Because again, it is a highly competitive market that we're in. And I'll just throw out one of the most expensive items that we have here within our facility from an equipment standpoint is a robot, a surgical robot. It's our intuitive Da Vinci robot. Those things cost $2 million or north of $2 million new. And that's a whole heck of a lot of surgeries you have to do on that thing to recover. And not every surgery can be done robotically. Not every surgeon is trained robotically. So you have to look at a multitude of things to see if it's worth that investment to have that capital. And fortunately, we have 2 of those here at Mercy Fairfield. So we're very fortunate with a lot of the things that we have, but then there's other things that we can't do. So capital is a huge item. And then that's really it for me. Have you had questions? I know I went through it pretty fast.
No questions on Facebook, but we'll open it up for questions for people on Zoom.
Liz, you had asked at the beginning what our vision for healthcare is.
Yeah.
I'm real interested. I'm a recent cancer survivor. I don't know if you know my story, but I switched over to a more naturopathic route, and I've been educating myself and others on the personal responsibility that we each have to take care of ourselves before we get sick. So what do we do to build our immune system? What do we do to stay healthy, to prevent the illnesses that are brought on by lifestyle and what we eat and lack of exercise? Do you guys have any kind of program set up at the hospital that teaches people that kind of stuff?
I can't think off the top of my mind. We have for new diagnoses, we do have select specialties that we have. We have a lung nodule program where we have a nurse practitioner that staffs that and works with newly diagnosed lung cancer patients. We do have some nurse practitioners within our women's center for breast cancer patients. And we obviously have diabetic educators to help educate those with diabetes. We have a weight loss program, to help those that need bariatric surgery, and then to maintain that weight loss post-surgery as well. But if there is something I don't know about it, it could be very well embedded within our primary care sector. I'm not positive.
Financially on those programs, do insurance companies typically pay for that?
Sometimes they do. We're actually, when I started here at Fairfield, I started here 4 years ago at Fairfield, and we have a pretty robust bariatric program. And we saw a lot more self-pay, bariatric sleeve patients than we do today. We are starting to see more and more healthcare plans cover a bariatric surgery. It's all about the health and wellness of associates of employers. So we are seeing them start to cover more health and wellness items.
So now I have a financial question.
Okay.
I have a unique type of health insurance. It's not health insurance. It's a share program. So I am in Liberty Health Share program. Do you know anything about those programs?
A little, not a whole lot. If I imagined your Liberty Health Share program, it's probably the employer and the healthcare system that they're connected with.
No,
Probably.
I'm self-employed.
Oh, you're self-employed?
Yeah, so what it is, there's a couple of these groups. There's a Christian group. Liberty Health Share is backed by Mennonites, I believe.
Okay.
They're a conglomerate of, when I go into a facility for any type of healthcare, I'm considered personal pay. But I have this support team behind me that negotiates the cost. I pay, my monthly premium for that plan, but I also have a deductible that I'm responsible for. And then after that, they have been covering everything. I mean, I'm a recent cancer survivor, like I said. So I had surgery, I've had chemo, I've had all of that. And this plan, it's been very beneficial to me, but I've noticed that what they pay the providers is minimum. My surgery was $34,000, they paid $20,000. So we still have 14 in negotiation. So I was just curious from the hospital standpoint, how they feel about those types of programs.
I I can't speak to that, but it sounds like if your invoice was 34,000 gross, that the 20,000 actually isn't too bad when you think about it. We don't expect that we're going to get paid the full amount that's billed. Because again, our contractual relationships with these insurance companies isn't 100% of charges. It's usually less than that. I actually don't even think I even know of a plan that pays 100% of charges.
I think the 20,000 is what they base that on, is that's what Medicare would have paid.
What the Medicare reimbursement would be.
Yeah, I think they cover what Medicare would pay, and then the rest of it goes into negotiation.
Yeah.
But why do hospitals charge what they charge and then not expect to get it in? Is there a way that, and this is an arbitrary question, not for Mercy or whatever, but is there a way that we could have like flat fees for everybody, that everybody gets charged the same? I know if I had insurance what my bill is, and I know as a personal pay what my bill comes down to.
Mm-hmm.
So couldn't everything across the board be more?
Wouldn't that be great?
Yeah.
If you cut all commercial payers out, maybe we could get there. Because Medicare and Medicaid, they do that. We get paid the same as Westchester, as Fort Hamilton. We get paid the same from Medicare and Medicaid as any of those. It's all within the negotiation with our payer contracting team, with the big insurance companies, like the Anthems and the Uniteds. It comes down to contract negotiation. How good are you, and how many? It really comes down to how many healthcare providers do you have access to for your patients that are under your plan as well. So they're also looking at access. That's a big thing that these insurance companies are looking for. Medicare and Medicaid are accepted at any facility that you go to.
It just seems so very complicated.
It is.
Liz, I have a question. There was a study done, I'm thinking now it's probably been 5 years ago, where this part of Ohio, we had some of the best access to healthcare in the country. So we're in top part of the nation as far as access to healthcare, but yet we're in like the bottom 4 or 5 as far as the health of our population. So, and I know there was some questions on to why that would happen. So with that being said, I'm just a little surprised that I don't see the hospitals combining forces and really targeting on specific health issues that they could actually, move the needle on. And from, and that question isn't necessarily for you, but now this one is. With that being said, from a financial perspective, wouldn't it make sense if the hospitals looked at addressing specific illnesses that are across the board that are rampant in this part of the country, like diabetes or something like that, and combining forces to do campaigns to change what the future looks like? Wouldn't that be a financial investment from the hospital's perspective into lowering the cost of healthcare long term?
It would. I totally agree with you. So what we haven't seen in the past is the healthcare systems working that great together within the local communities. We are starting to see better working relationships there within the most recent years. And I also have seen us working even better together through this pandemic. We are all relying very heavily on each other through this and helping each other. So if anything good comes out of this, it's really us working better together. To be completely honest, with our 5 facilities under Bon Secours Mercy Health in Cincinnati, we have work to do as well together. And we all kind of work in our own little silos sometimes. So we are trying to do just that. So we have to get that right before we can even think about working with the Christ and the Tri-Health and the UC and the Ketterings of the world, right? So it's a constant battle, and we see glimmers of light more than we have in the past. And we are actually, if you think about our hospitals and you look within the four walls of all of them today, they are all pretty much full access hospitals. You can go have heart surgery at every single one of our facilities right now, with the exception of Claremont. And that's a major surgery. And do we really need to have that at every hospital? So really trying to focus on where do we provide that care and become that be the specialty of that hospital that you're really good at. So that way, you know, we can all specialize in something a little different, and you really can provide better care to that patient. Because when we're all trying to provide the same thing, that's when it becomes competitive, and that's not what we need for our patients. We need to provide excellent care. So we are getting better, we're not there.
Anyone else have questions? Well, thank you so much, Liz. That was a great presentation. We really appreciate it. And we will see everyone next Tuesday at 9 a.m. at Coffee and Conversation.
Great, thank you.
Thank you.
Thank you so much.